Cost effectiveness, treatment of low back pain and neck pain, comparing expenditures for primary care medical, physical therapy, and chiropractic management. Back pain is the second most common reason adults consult a primary care provider following upper respiratory infections. Approximately $90 billion is spent on the diagnosis and management of low back pain alone, and an additional $10 to $20 billion for economic losses in productivity each year. Clearly, everyone wishes to decrease this degree of expenditure by emphasizing those approaches that work and distinguishing them from those that are least effective. In addition to keeping costs down, it would be important to use approaches that are safe, effective, and beat the natural history for back pain. First, it's important to look broadly at the most common approaches to spine pain and tease out their relative costs compared to each other. When viewed over years, it's important to factor in and adjust for inflation so that the comparisons are constant. A new study takes this approach, comparing primary care medical, chiropractic, and physical therapy management of low back and neck pain, and compares their relative costs over a period of 9 years. The title of this publication is Where the United States Spends Its Spine Dollars, Expenditures on Different Ambulatory Services for the Management of Back and Neck Conditions, published in Spine in 2012. So where did they get their data? Their approach was to use data from the Medical Expenditure Panel Survey, or MEPS, to examine expenditures on health services that are used to manage back and neck conditions from 1999 to 2008. The MEPS is conducted by the Agency for Healthcare Research and Quality. They captured data on healthcare utilization, expenditures, and healthcare status on the general population. There are 3 sources of data comparison. The first is from household surveys. This information is then compared to information for those same patients by their healthcare provider and insurance provider. Patients were asked to identify the primary provider of their back-related service as either a primary care MD, chiropractor, or physical therapist. The designation primary care MD included family physician, internist, or general practitioner. Also, starting in 2002, the MEPS captured information on the specialty of the medical physician, allowing comparison of expenditures on primary care versus medical specialty services from 2002 to 2008. The sampling stats are fairly impressive. From 1999 to 2008, the number of individuals ranged from a low of over 23,000 individuals in 1999 to a high of over 37,000 in 2002. Response rates were very good, ranging from 57% in 2007 to 66% in 2001. To ensure respondent confidentiality, the MEPS limits ICD-9 codes to 3 digits. The level of detail of diagnosis is thereby significantly limited. By combining, for example, all ICD-9 724 conditions without the next decibel discriminator, 9 separate conditions are combined into one category, which was about half of all patients seen by providers. This included wide-ranging conditions for the thoracic, lumbar, sacral, and coccyx areas, unspecified backache, lumbago, and also sciatica. Also, only the primary ICD code was used if multiple codes were entered on an individual visit. The researchers emphasized that their study was for common ambulatory visits and not to estimate all uses or expenditures. Another comparison was health status change. The researchers used the MEPS categorization of excellent, very good or good, and fair to poor. Additionally, they collected patients' BMI, smoking status, and SF-12 scores. Approximately 6% of U.S. adults reported an ambulatory visit for a primary diagnosis of a back or neck condition, equaling as many as 13.6 million in 2008. Here we can see the annual average visits to each practitioner. For medical doctors, it was about 3 visits per year, for chiropractors about 8 visits per year, and for physical therapists a wide range that averages to around 9. Between 1999 and 2008, annual expenditures on medical care for these patients increased by 95%, from $487 to $950. Most of the increase was accounted for by increased costs from medical specialists as opposed to primary care physicians. In fact, the mean annual visits to medical specialists increased from about 7 to around 9 from 2003 to 2006. Here we can also see the average annual costs for chiropractic and physical therapy. All of these estimates were inflation adjusted using the Consumer Price Index. For chiropractic, the mean expenditure was stable. Also inflation adjusted, the range was $473 in 1999 to $662 in 2007. For physical therapy, the confidence intervals are quite large, so this limits the conclusions drawn, but the annual expenditure per individual did reach as high as $1,543 in 2002. Not surprisingly, having fair or poor health status or any limitation predicted higher expenditures. Higher healthcare spending was found for those who were privately insured and living in an MSA, at least for those using medical or chiropractic services. An MSA is a metropolitan statistical area representing a city of at least 50,000 people or an urban area of 100,000 people and includes counties in that area. The researchers conclude that medical expenditures have increased substantially, but that this is not due to primary care management, but due to an increased use of specialty services. They also conclude that the health status of individuals with a primary diagnosis of a spine condition has not improved over this same period of time. They refer to the 2007 study by the Centers for Medicare and Medicaid, CMS, that concluded that expansion of chiropractic reimbursable services would cause an increase in costs and likely reflect that the low and stable costs of chiropractic are due to limitations on reimbursement, whereas medical specialists rely more on reimbursable advanced imaging technologies. One limitation of this estimation on medical expenses is it did not include pharmaceuticals, which would have substantially increased costs. This study is important in that it demonstrates the cost-effectiveness of chiropractic care and that it is likely that medical care that includes either pharmaceutical management used in 80% of medical management of spine conditions or imaging use with specialty care comparatively increases the cost-effectiveness of chiropractic care. They emphasize that chiropractic care needs to be an important consideration as a component of any new healthcare system changes.